Good evening, everyone. Welcome to tonight's living room. I'm Danielle Hicks, Chief Patient Officer here at GoTo for lung cancer. For those of you who may not know me, and for those of you who may not know this programming, this is our lung cancer living room. We've been running this program since about 2009, and tonight's meeting talking about the best of ASCO, the American Society for Clinical Oncology. For those of you who are no strangers to this room or any of the programming that we provide for our patients and caregivers and lung cancer community here, it's an annual meeting where all of the research that's being done throughout the year and the years, data is presented. So we get to see how things are progressing and what new exciting things are coming down the pike. And I couldn't be more thrilled to have Dr. Roy Herbst here. Dr. Herbst is Ensign Professor of Medicine. He's the Deputy Director at Yale Cancer Center, the Assistant Dean for Translational Research at the Yale School of Medicine. We've done a regional living room out at Yale with Dr. Herbst and some of his colleagues, so we are thrilled to have him back with us tonight. Tonight, as I said, we're going to be talking about the latest and the greatest and the exciting things that are coming down the pike, and hopefully, fingers crossed, will soon be available to those that need it. You're going to hear a lot of big words tonight, a lot of big drug names. We will do our best to bring it down to a level that everybody can understand. When I first started in this space and I'd go to these green as can be, go to some of these conferences to try to see what was new and exciting and what was happening, there wasn't a lot. And when I remember my first time walking through ASCO, you were hard pressed to find anybody working in lung cancer. And now you're hard pressed to find anybody who's not working in lung cancer. So things have really, really come a very, very, very long way. And not that a cancer diagnosis is exciting, because we all know that it's not, but exciting things are happening to help support people that are diagnosed. So that's what we're going to jump into and we're going to talk about. One of the things that was very exciting for me, and I think the lung cancer community in general, were some of the conversations that were happening during the plenary session. So Dr. Herbst, before you talk about sort of these three key things that happen, can you explain what we mean when we say a plenary session? What is that?
A plenary session is the session where everyone who can will attend that session. There's nothing else at all going on at the same time. There's one plenary session at each ASCO. I've been fortunate. I've given 2 plenary talks in the last 5 years. I didn't have one this year, but I sat in the audience, and I believe 3 of the 6 talks were lung cancer related in this plenary session. Now think about it. You're at the Chicago Convention Center, the biggest convention center in the United States, probably the world. There must be 20,000 plus people in the room. The room's packed. They're actually saying, fire marshal says you can't come in here. You need to go to another room to watch it on TV, which I find pretty ridiculous. You might as well be home. But everyone is watching. And there's discussions of 3 different papers that are showing transformative data that's benefiting patients with lung cancer. Both types, by the way, non-small cell and small cell. We can talk about that. So I was just thrilled. I actually did a plenary last year on a similar abstract. There was 1 abstract there, and that got a lot of attention, but 3 abstracts out of 6 on lung cancer, really incredible.
It really is, and I think I can't shout that from the rooftops loud enough. I mean, these plenary session conversations are really held up as the most impactful information to be presented at a conference. And when you're looking at a conference that's covering all cancers and not just lung, for 3 to be directly related to lung cancer is pretty big. So let's kick it off with presentation 1, which was on the comparative effectiveness of early palliative care delivered via telehealth versus in person. And this is near and dear to my heart, and I know a lot of folks in this room, because we tout palliative care as a must-do conversation from the very beginning. So Dr. Herbst, can you tell us a little bit about what they found there?
Yeah, so we've known for a while, people like Dr. Jennifer Temmel at Mass General, Tom Lynch, and others did large studies way back and showed that when you treat people with lung cancer, you're treating them to try to kill the cancer. But you can't forget about the person, which I think this living room is all about, and quality of life, how they're tolerating their therapy. And it's been known from the study almost a decade ago, maybe a little more, that when you add in supportive, I like to call it supportive palliative care at treating symptoms, patients do better. And it intuitively makes some sense. If people are stronger, better able to tolerate their therapies at full doses on time, their mental status is improved, that all helps their general gestalt, their general outlook. So now in this era of COVID and this era of, limited resources, go try to get an appointment these days for a subspecialist. The idea was, could some of this palliative care be done via telehealth versus in person? And the study, it's a big study, and there are some small imbalances between the arms. But bottom line, my take on it is that you could do some of this by telehealth, and the results look reasonably good, almost as good, if not the same. So what does that mean? That means that, sure, I happen to believe in the touching of the hands and meeting with people, but people live all over this country. They're in rural areas. They're in places where they can't get into the physician. They're their supportive caregiver. It doesn't have to be a physician. It could be anyone on the medical team, or maybe their family members don't have the time or the resources to get them there. So I think that the fact that now the data are supporting this by video, I think we'll see more of this. There are some problems with this. I think problems would include not everyone has access to a private video area to do this. There's still limitations in caregivers. There are restrictions about doing these videos across state lines. Telehealth isn't what it used to be. During the period of the COVID pandemic, I could do a telehealth with anyone, in the country. Now I'm limited to my areas of my license, which is still just Connecticut. So, but that said, I think this shows palliative supportive care in lung cancer makes a difference, and it can be done in a more generic way.
Yeah, I love that. And just to clarify for folks who may not know, a lot of times there's a confusion between palliative care and hospice care. Palliative care, in the sense that we're talking about it right now, is meant to be supportive, as Dr. Herbst said, and the data does suggest that early palliative care not only improves quality of life, but overall survival, particularly in people with advanced disease, which we know most people diagnosed today, or the majority, I should say, of people diagnosed today with lung cancer are. So thank you for that. Okay, number 2. This is an interesting one, and it's looking at targeted therapy after chemoradiation for metastatic lung cancer.
Targeted therapy, that being EGFR therapy, that was one of the first things I did when I went into lung cancer research back in 1996, 97, working at MD Anderson with John Mendelsohn and Ki Hong. The first EGFR inhibitors went into clinical trial then. I know that for sure because I was there. We did it. And 20 years ago, 2004, after using these EGFR inhibitors for 6 years, we found EGFR mutations. The fact that there are mutation-specific DNA abnormalities in patients with lung cancer. And in this 10-15% of Americans who have that, we can treat with a specific drug, always in the advanced setting, and see tumors shrink. But now, turning the clock forward, now we're combining these new targeted therapies with other effective therapies, that being chemo and radiation therapy. So we know that when someone has lung cancer that's locally advanced, meaning in one lung, with lymph nodes in that lung, or maybe a few of them crossing over to the other lung, we call that stage 3A or 3B. Now there's a 3C as well. But if you have stage 3 lung cancer, the therapy has been chemotherapy, radiation together. Some of these patients get surgery, but a good number get chemo, radiation, concurrent therapy. But if these patients happen to have that EGFR mutation, they would just stop and we'd watch and wait. But now, based on a number of studies, including a study that I presented last year called ADORA, that used adjuvant therapy with osimertinib. Osimertinib is a tyrosine kinase inhibitor, an oral agent that targets epidermal growth factor receptor. Many of you know it. It has very good penetration into the brain. It works in the brain. It's specific to the mutant EGFR receptor, meaning it has fewer toxicities than the early generation drugs. It's been shown to work post-surgery. So now what the investigators did, and this was presented by Dr. Suresh Ramalingam from Emory, he and his team showed that in these patients who got the drug after chemoradiation, and they either continued the drug for until they failed or they got a placebo, there was a phenomenal benefit in decrease in progression of cancer. I think it was an 80+% benefit. So what does this mean? It means that practice changed as I'm sitting there, patients that have this EGFR mutation, and by the way, most of the patients on this trial were from Asia, or many of them were, but we see this in the U.S. now because we're going to screen for it. We have to profile patients. For anyone who's listening to this, you need to know in advance before you get chemo, radiation, surgery, what your tumor shows. These patients benefit from getting the osimertinib. So this was, I think, I would say this was the most influential lung cancer abstract of the three. Practice is changing. I haven't seen the FDA approval yet, but it will come. But it's certainly already changing the compendium and practice. And if someone came in as my patient with an EGFR mutation and locally advanced lung cancer, and after our tumor board, we all got together, the chemotherapy person, myself, the radiation therapist, the surgeon, we decided that we were going to go this route. I think we would probably go ahead with the osimertinib afterwards.
We've said osimertinib a lot. You guys might have heard us refer to it here or in your world as Tagrisso. So just to confirm that that's what that is. Larry, what you got for us?
I was just wondering if in practice, with the success with osimertinib and EGFR, if it's practical or if you're seeing oncologists apply the same philosophy to other mutations.
That's an excellent question. I think we will see that. It's already been done with the ALK, the anaplastic lymphoma kinase gene fusion, which is about a third as common as EGFR mutations. But there was another, we'll talk about this, lorlatinib, another drug that was presented that works there. Yes, I think we'll start to see that. That drug's already been shown, the ALK, in the adjuvant setting. I don't think we need to do a phase 3 trial for every one of these targeted agents. I think what we'll need is we'll just need data to show that maybe a single arm phase 2 trial that it can be given for a prolonged period of time and be tolerated in the earlier stage disease. But I would bet 2-3 years from now, someone will come in with lung cancer, and if they have a targetable mutation, which is there are at least 9 of them now, there'll probably be discussion of getting one of these agents, these oral agents, post-surgery. Right now, it's only approved in the adjuvant setting for the Tagrisso and the alectinib, that's the ALK, and the data we just talked about with Tagrisso, osimertinib, is still pending approval. But I do think that we're not going to have to do a big phase 3 placebo trial. How can I, knowing that these targeted agents, some of them work so well, subject someone to a placebo trial in the future? So I don't think we'll be seeing many of those. I think we'll be seeing a rollout. But again, not every one of these drivers or mutations is as good as the other. So there'll have to be I guess we'll have to do some real world data analysis. We'll have to start these trials and just collect the data. So I would say that even if we don't do a clinical trial, we have to collect the data, and hospitals and big insurance companies will need to collect these data because we have to show that it works and that it's tolerated. But I think that it's going to become the new paradigm. So we have always talked about personalized therapy. Now I like to say it's even more personalized therapy. So we've really moved to a new generation of targeting cancer, lung cancer. The reason why these trials were placebo-controlled, because I'm often asked these questions, sometimes in a very critical way, and there were no data to support this when we started the Adura trial last year or the LAURA trial, as it's called this year. But now that there are these data, I think things might evolve a little bit differently.
Yeah. This third plenary session talk was around immunotherapy and adding it to standard of care for limited stage small cell lung cancer. So anytime something new happens in small cell lung cancer, I get extra excited because so little has happened over the last 50 years, and that's really started to change over the last few. So Dr. Herbst, what do you want to say about that?
Well, who would have thought, 10 years ago, we'd be talking immunotherapy, not only in small cell, but non-small cell lung cancer. But immunotherapy has changed the landscape. I think most people on this living room know, but, lung cancer is one of the top 2 or 3 cancers where when you reactivate the immune system with these so-called checkpoint inhibitors, drugs that allow the body's own immune system to target the cancer, whereas prior to that, it was being blocked by forces that the tumor produces, we can see a benefit. And of course, in non-small cell lung cancer, I think everyone knows, or we can talk about it, phenomenal benefit. But in small cell lung cancer, Danielle's right, there hasn't been that much benefit. About 3-4 years ago, we saw, maybe it's 4, we saw that durvalumab, a PD-L1 inhibitor, targets an immune checkpoint in patients with advanced small cell lung cancer. We call that extensive disease, whose small cell lung cancer is spread outside the lung. They would get their chemotherapy, platinum therapy, something called etoposide, and then they would also get this drug, durvalumab, and actually they saw a benefit in their progression-free and overall survival. But to this day, no one had looked at this in more limited small cell lung cancer. In limited small cell lung cancer, this is, small cell lung cancer is about 10 to 15% of all the lung cancers, and limited is probably about a quarter to a third of them. So in these patients that have limited disease, the disease is confined to one lung, to one area where one could give radiation therapy. And in those patients with limited small cell lung cancer, they get chemotherapy and radiation together. And actually, 1 out of 5 is cured. It's very potent. But that's not good enough. We want 100%. So we're always looking, and that should be a theme of this living room. Progress being made, but we need more. We always need more. So this durvalumab was now used in those patients. It's called the Adriatic trial. These trials all have names of major bodies of water. But in the Adriatic trial, the durvalumab was used afterwards, and lo and behold, improvement in progression-free survival and in overall survival. So now, very quickly, it's, again, still awaiting the FDA approvals. I was just on a guidelines call today, and we added this to our guidelines, but we're put an asterisk waiting for the approval. Now, if you have limited small cell lung cancer, immunotherapy now becomes part of the equation. So this abstract also was met with a great deal of excitement. Dr. David Spiegel from the Sarah Cannon in Nashville presented it. There was a discussion for this as there was the other one. Both discussed and said, we have a new standard of care. And again, can't remember an ASCO, and I've been going to ASCO since the 1993, so 30 years. I can't remember, and I haven't missed a year. Gosh, that's a lot of meetings. But I can't remember seeing 2 big presentations like this, one in small cell, one in non-small cell, changing practice. And, gosh, I get 2 or 3 CVs a week from young people wanting to work in the lung cancer area. Back when I got my job, I just waltzed right into the job because no one wanted it. But we're making progress.
Yeah.
But again, I know there are people on this call who are still fighting lung cancer. It's not good enough. There's tangible progress. I can tell you I've seen it over my 25-year career, but we need more. And that's why research and science is important. But I also, and the reason I love these living rooms is people need to have knowledge about what they can get, because I worry about people who never get offered these immunotherapies or get offered these targeted therapies or get offered the profiling. So that's something that all of us have to do, is increase the awareness so that we can help more people with this disease.
Yeah, from your mouth to God's ears, I think that's one of the things we talk about so much here, particularly in the community setting, particularly in the more rural community settings, where access to this type of information takes a little bit longer. It's like swimming upriver to some of these healthcare providers that are providing care in those centers. So the more educated the patients and their caregivers and loved ones can be to have these informed conversations with their docs, the better. So those are the 3 plenaries. Very, 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 very exciting. We just talked about IO, so I think maybe, Dr. Herbst, if it's okay with you, we'll jump in to a little bit more about IO. What else was new and exciting that was sort of a buzz around ASCO?
You can see commercials. I don't think we have any commercials during our living room, but if you were watching the All-Star game, which you can all watch after this is over, they're having commercials. They're having Stand Up for Cancer. They're talking about IO. IO really works. However, in my experience, and I was also an early adapter of that, we did a lot of the early trials, at Yale. My colleagues, Mario Snow, Harry Kluger, Scott Gettinger, I can tell you that 1 out of 5, I do think we cure people in the advanced setting with IO. But right now, IO in the advanced setting works best in people who have smoked. If you've not smoked, ironically, the IO does not work as well, the immune therapy. And in about 30-40% of patients, while it might work initially, patients will become resistant. So there's a lot going on. What are the new combinations? One of the things that, we presented, from our lung cancer master protocol group, I think Dr. Karen Redcamp, Chanel Gray, myself, and others, we're taking pembrolizumab, the PD-1 antibody, also known as Keytruda, and we're combining that with the anti-VEGF-R2 antibody ramucirumab. I believe that goes by Cyramza. So we are looking at new combinations in the IO world. So I think that was exciting. There are some new vaccines. There are what we call T-cell engagers, and that's one I want to talk about. It sort of preceded ASCO, but it was discussed a lot at ASCO. ASCO's not just abstracts of new data; it's a lot of education, and that's tarlatinib. Did I say that right, Danielle? How do you pronounce it?
Yeah, tarlatamab, I think. Yeah.
Yeah, I need it's like the King's Speech here,
Yeah.
I gotta.
We call it Tarla for short.
So the big T, Mr. T.
Yeah.
That drug is a game changer because what it is it's a DLL3, which is a protein that tends to be increased in small cell lung cancer. One arm, it's an antibody. So antibodies have two arms. So one arm binds to the DLL3. These are my fingers I'm moving. And the other arm has what we call CD3. CD3 is what you call a T-cell engager. It tells all the immune cells, hey, come over here. There's a problem here. I need you to kill the small cell lung cancer. So this, we call it a bispecific antibody. This drug, the engager, really works in people with small cell lung cancer who have had the therapy I mentioned earlier, who have failed it, their cancer's growing. It's a pretty desperate situation. And I'll tell you, I just really, I always like to make the point that, yeah, we're all positive about progress, but we all know people, and I know way too many people because I see them every day, aren't benefiting from these therapies. But I am seeing in small cell lung cancer people who benefit from this tarlatinib when they failed all the other therapies in small cell. So that's the really good news. And the drug's approved now. We ran protocols at Yale, but now it's approved. Protocols were run at many places. Clinical trials are good. Always look for clinical trials because you can get the drug earlier. But now you can get the drug on formulary. So that's the good news. 20, 30%, maybe 40% of patients will respond when their tumor hasn't responded. And these are the patients in the most advanced small cell lung cancer. Now it's being moved up to the front line where it might even have more effect. But nothing is without the cost. And the cost is, and I don't know if we should talk about this now, Danielle.
Sure.
Patients do get side effects, and it's complicated. These clinical trials were done in very selected patients. They were done in sites where there was a great deal of knowledge and they knew how to use these drugs. And now these patients can have adverse reactions. When you rev up the immune system, did anyone ever have poison ivy? That's a reaction to the immune system. So imagine having that sort of inflammation throughout your whole body. It can be pretty bad. So many of these patients are treated in the hospital. So that means we have to have access to the hospital. They have to get in the hospital. We have to have a bed. And there are some, small percentage that have what we call CRS, cytokine release syndrome, which gets the whole body shaken up with all these interferon, interleukin, and this is something we have to watch out for. So I am a big believer in community sites administering these drugs, but there has to be a back and forth with people who have used it before because there is a bit of a learning curve. But again, IO has made it into small cell lung cancer, again, which is fantastic. New combinations in non-small cell lung cancer. There was a ton of stuff at the meeting, the American Society of Clinical Oncology, ASCO, about biomarkers. I'm a big proponent of science driving therapy. If we just start combining drugs, maybe we'll hit something that works eventually. But we need science to de-risk it, to understand if a lung cancer tumor is growing after it's had immunotherapy, why? Has the tumor lost the ability to respond to the immune system? Is there another protein that's come onto the surface that's causing that tumor to grow? These are all things that I think are going to be the future. Even more personalized, targeted immunotherapy, and we started to see some of that at ASCO this year.
Yeah, I agree. But before we jump into the targeted therapy sort of portion of this conversation, if you wouldn't mind explaining a little bit about really high level, just what it is and why it's so important.
So epidermal growth factor receptor, first drugs go into clinic 1996. The mutation's not discovered until 2004, meaning it took 8 years until the biology, the technology, the cooperation occurred to figure out why do only 10% of people really benefit. You got to know who's going to benefit. Why? Because you want to find those people so they can benefit more. But it's wrong to treat the 90% who aren't going to benefit because they're just going to have side effects and you want them to get other things, other drugs. So what's the problem? Even though we've known about this mutation test, and we just had a big meeting at Yale, 250 people there. There are some articles in the press, to celebrate 20 years of the discovery of EGFR mutation. We had several panels. There's a beautiful article in the Cancer Letter if you go to that online. But it took years, and even now, not everyone is even profiled in the advanced metastatic setting or the early setting, meaning that when you get diagnosed with lung cancer, it's not enough to say this is lung cancer, or it's not enough to say it's non-small cell or small cell lung cancer, but that tumor has to be sequenced. We need to know if any of these abnormalities are there because they drive treatment, and we still don't see it. It's probably at 80%, but it's lower. And where is it lower? In people that don't have resources, people that lower socioeconomic status. There are these what we call the socioeconomic determinants of health. People in rural areas. You can come into Yale, big center. But what if you're in the middle of the country and you go into a small clinic? It's critical. We know all this. What good is all the science and matching the right patient to the right drug if you don't find that patient? So we're trying to increase that awareness. These sequencing tests are much more inexpensive. They can be done on much less tissue. Used to be you had to do a big biopsy. Now it can be done a small needle-guided biopsy. It can be a biopsy that's done through the mouth, through a bronchoscope. We can even do it as a liquid biopsy. Meaning we can take blood and send the blood off because you can measure things floating around in the blood. Now those are not quite as sensitive as the tissue yet. But if you find it in the blood, you can probably stop and not have to send it in the tissue. So I can tell you, I ran this for 11 years, something called the Lung Cancer Master Protocol. It provides free sequencing, free profiling. We ran it at 700 sites. This is critical. If you leave here with one thing tonight, we do need to make sure that if you have lung cancer, someone in that room, either you, your doctor, social worker, the nurse, someone has to say, have we profiled the tumor? Let's get those results within 10 business days. Let's figure out what the best therapy is. And they matter both for the earliest lung cancers and the most advanced lung cancers, in large part based on that plenary talk, the LAURA study we talked about. So I'm sure you want to emphasize this even more, Danielle, but profiling tumors, knowing what drives that car and what's wrong with that engine you can't fix it otherwise.
Yeah. Yes, and yes. I mean, I think even the 80% of folks, that we think are getting tested now based on the most recent data, but data is always kind of in the rears a little bit. We're talking about late stage. We aren't talking about early stage, where this is a way newer sort of concept and running this type of biomarker testing up front. You've heard Dr. Herbst talk about the ADORA trial, which really sort of transformed how we looked at treating early stage surgical patients where there was still a too high likelihood of recurrence, right? And the impact that this has had there. So yes to biomarker testing. The days when, access to the tissue or the quality of the tissue because it was necrotic or there wasn't enough or whatever, we're really past that, because there are not only more innovative ways, to Dr. Herbst's point, to access the tissue, but liquid biopsy is a really good option for those who either can't tolerate another, a biopsy, or the access to the tissue just wasn't there. So
when you have advanced stage disease and you progress, do it again, biopsy again.
Yeah, I would agree with that. Sometimes in these driver tumors, like epidermal growth factor receptor, ALK, RET, NTRK, MET, you can get something else. So there are two ways one can have resistance. We call it on target or off target. I'll simplify. You can either have another different mutation develop, in which case you have another drug, or something can happen within current abnormality that makes the drug no longer effective. But if we know that, there's so much research going on and so much science and so many databases, and dare we, you guys are out there in the AI capital of the world. Someday we're going to be able to figure out what the right drug is to use in the resistant setting. So yes, rebiopsy is important. I don't think it should even need to be part of a clinical trial. At our center at Yale, we routinely rebiopsy tumors, and I think it can be done with liquid biopsy many times too, by the way, because if the cancer has spread, unfortunately, once it's already spread out of the lungs, you usually can pick it up in the blood, and these liquid biopsies are pretty quick and sensitive. Sometimes you get it back faster than the tissue biopsy.
Yep, very, very true. Any presentations or research about KRAS G13C?
And we can target RAS. RAS, as opposed to all the other mutations, tends to occur in people with a history of smoking, though not always. There are 3 different codons, G12, 13, and 61, that can have KRAS mutations. Kevin Shokot and a brilliant group out there at UCSF started the whole research work that in codon 12, we call it G12C, we have 2 drugs, adagrasib and sotorasib, that work, albeit we're still trying to make them work better. But yeah, if you happen to be that, and about 12% of lung cancer patients, adenocarcinoma, will have that KRAS. It's about 70% of the lung cancer KRASs. But then there's also G12, G13, and 61. So there are some what we call pan-RAS inhibitors. There were some posters on that. I think a lot of that work is early. It's in the early phase 1. But we do have a few drugs coming down the pike from Genentech, for example, and others, smaller biotechs that do have activity against multiple KRAS alleles. So stay tuned. But we realize that now that we're testing for all these abnormalities, we're finding things that we don't have drugs for. It won't work quite the same as the G12C, because that C, the G12C, that cysteine, that was what was used mechanically to really bring the drug in and make it work so well. But there is hope for what we call pan-KRAS inhibitors. And I think we'll see more of those at the ESMO meeting coming up in September and at the World Lung Meeting. There's a big World Lung Conference. You can all go to that. It's in San Diego, not far from you, well, closer to you than me. And that's going to be September 7th, 8th, 9th, and 10th. And I think there'll be some stuff on that as well.
With the T-cell mechanisms or technologies, is there any research being done on non-small cell lung cancer?
Yeah. This is the whole area of what we call T-cell engagers. And there are many groups that have what we call bispecific antibodies. The key is you want to bring this CD3 in. Everyone is doing that. There are different ways of doing it. Some are more potent than others. So you want to bring in the CD3 that's going to attract the T cells. The question is what you use for your bait on the other side. So you want to catch the fish. I'm just making this up as I go along, but it seems to be working. You want to catch the fish, but you need the right bait. So in the small cell, the bait is DLL3. In the non-small cell, what is the bait? Is the bait EGFR? Is the bait CD26, CD28, some protein? That's where it gets a little bit tricky. So there are many of these that are coming forward. They all have the concern that you want them to work well, but if they work too well and they activate all these cytokines, you're going to have toxicity. But I happen to think that this, in my opinion, in non-small cell lung cancer, and is going to be the major area in the future, because 50% of lung cancers, we studied this at Yale with my colleague Li-Ping Chen, one of the discoverers of PD-L1, Scott Gettinger. We have a project in a big NCI grant called the SPORE. 50+% of lung cancers, you look into that lung cancer, when you analyze it, there are no T cells. So it means that you have a lung cancer and there are no immune cells in the lung cancer. So it doesn't matter how many of these checkpoint inhibitors we give to this patient. If the army is not there, it's not going to work. And the army can't get in for some reason. So finding ways to get the immune cells into the tumor, whether it be through these CD3 engagers, whether a recent paper by Dr. Chen that showed that there are these what we call T cells disruptors. There are things that can disrupt the microenvironment so T cells can get to the tumor. Bottom line, that's going to be something I predict that we'll see much more of. Stay tuned. But research continues at a more fervent pace than ever before. It's translational research, meaning it starts in the lab and it moves to the clinic. And people like myself and my colleagues and all of you as patients or patient advocates or interested parties get people to look at clinical trials, to give their tissue for analysis, because we have to continue to raise the bar, not happen with a status quo. It is progress, but clearly not enough. We always have to be ready for the next lung cancer cell to start to grow.
Agreed. Okay, EGFR. What's happening in EGFR?
So much is happening there. So one, in the frontline setting, as good as Tagrisso osimertinib is, and it is pretty good. The median time to progression is approaches 2 years. That means half the people progress before, and half the patients progress after 2 years. So we always want to do a little bit better. So there are two things that are happening. One is something called FLAURA2. And what that is taking chemotherapy and adding it to targeted therapy. What are the pros? It has been shown to improve the progression-free survival in advanced metastatic disease, meaning it does move to the right that time when patients might progress. That said, it hasn't yet been shown to improve survival. So many people say, well, without seeing that this is a survival benefit, I'm a little bit more cautious because the cost of this insurance is high. You have to get chemotherapy every 3 weeks. That means you can't travel to Paris for the Olympics because you have to find some place to get your chemotherapy. That means that you're going to have the side effects of chemotherapy, the low blood cells, the hair loss, the potential kidney problems. So stay tuned, but there are some thoughts that maybe if someone has very aggressive disease, we might give them the chemotherapy. But this FLAURA2 trial, we're still waiting for its final survival. Then there's another approach called Mariposa. Interesting name is Mariposa. These are studies, and there were different variants of these trials presented at ASCO. Not the main study, but some of the sub-studies. This is a drug that targets, it's an antibody that targets both EGFR and also targets c-Met. And when that's used and combined with a cousin of Tagrisso, lazertinib, that's been shown to have an effect over osimertinib alone. And we're, again, still waiting for survival on those trials. But I think that might be an approach in the future, again, to try to lengthen the time that someone becomes resistant to the Tagrisso. That said, these trials also have more side effects and infusion reactions and vascular thrombosis issues requiring IV, whereas the osimertinib Tagrisso is oral. So these are things that are going on, and I think the world is watching, and we continue to get updates to these from time to time. Then, of course, what to do in the most refractory setting when people become resistant to EGFR. That's an area of our research here at Yale. That we need to sort of figure out what are the next level drugs. Many people are using what we call an antibody drug conjugates. I think you'll probably get to that next, so we'll save that. But, looking at new cocktails, new combinations. There's a trial called Orchard that's looking at new combinations in this setting. I would say we don't have the answer to that yet. There is some thought that the amivantamab, the dual antibody, might have a role here in combination with chemotherapy. There is some thought that you can resequence and find a new mutation. There is some thought that maybe new drugs will be developed, maybe even figure out how to use immunotherapy in this setting. But that area, I think, is moving slowly, but there is a lot of research in that area. We'll have to wait for another ASCO.
As always, there's a lot going on in EGFR, but I think, in talking with folks all over the country and the world, really, there tends to be a little jealousy with some of the other mutations about EGFR, but it's been around longer, right? It's like the older sister who's there's more information sort of known about it. But we do have one thing, Dr. Herbst, that you sort of outlined here for me around ALK, and that was the Crown study of lorlatinib versus crizotinib.
Yeah, so this is interesting, and I'm actually trying to get a patient onto this regimen right now. So ALK, like everything else, there's first generation, second generation, third generation. It's like everything gets a little bit better. We want it to be more effective and less toxic. We have 3 drugs now that are approved that we use routinely in ALK: alectinib, brigatinib, and lorlatinib. Alectinib and brigatinib are probably used more in the frontline setting. Lorlatinib works in a refractory setting, has very good brain penetration. So until ASCO, most of the practice had been to use the lorlatinib only in refractory disease. And actually, most people probably use alectinib because of its toxicity profile in the United States. Well, at the Crown study compares lorlatinib to crizotinib. Here's the problem: it's not comparing it to the second generation drugs; it's comparing it to the first generation drugs. It's because it's like, how do you do your poll? Dare I say it? Poll is a difficult topic these days. But here's the problem. So the Crown study showed a 5-year survival that was extraordinary. A 5-year progression-free survival for lorlatinib. It was one of the best ever seen over crizotinib. Now, this was not new data for us. We'd seen the Crown study 2 years ago, and it looked good at 3 years too. But with these data and with the side effect profile that looked like it was reasonably well tolerated, you do worry a bit about cognitive issues with lorlatinib, and it can cause some fatigue and nausea and vomiting. I think those data are quite compelling that, at least the number it's put on the board, again, not able to compare it directly to the alectinib or brigatinib, but at least the number that it shows is the highest number we've seen. So I think that this is a discussion, but I happen to believe that in someone who is of not having any CNS problem to begin with cognitively, who seems like they have a reasonably good performance status, meaning that they're strong enough to come in and be treated. I am trying to offer lorlatinib right now, though we're at a bit of a juncture right now. It still hasn't. The insurers are still getting the word out. The Crown study is so recent; it's only been a month.
And I'm being mindful of time, and I think if we can just take maybe 5 minutes and talk about the antibody drug conjugates, because this is a fairly new when we're talking about treatments for lung cancer. I know we've talked about them here before, but not in any detail. So what do we have going on there?
As we learn more about targeted therapy and about resistance, and immunotherapy and about resistance, so please know that all of us that work in the field understand that it's not a home run until everyone benefits, until we can treat resistance. So we're constantly working on new things. So that's principle one. But antibody drug conjugates are a more clever way and a more specific way of giving chemotherapy. It actually started in breast cancer with trastuzumab, and where you basically take an antibody that on one end the bait is Herceptin, then you have a little bit of a linking piece, and then on the other end you have a payload, and the payload is your bomb, your toxin. So we're doing this now in lung cancer. We know that there are different sites in lung cancer. We can use HER2. We can use something called TROP, which is actually upregulated in about 50% of lung cancers. And we can make these antibody drug conjugates where we deliver the chemotherapy a bit more specifically. And the results are looking promising, more promising for the HER2. The problem is HER2 mutations are only 2% of lung cancer, and upregulation maybe another 20, 30%. But the HER2, the Enhertu being used in lung cancer with some benefit. And now the TROP2, there's a number of different TROP2s out there. Their data has been sort of mixed, but I would think that, given that the immunotherapy is not a panacea for everyone, and that I haven't yet told you that we figured it out, the targeted therapy, even in EGFR that we've known about for 24 years. So we're making good progress, but with all the others, we're going to have to do a lot of work. These targeted ways of giving chemotherapy look somewhat promising, though. I'll be honest, it's not as promising this year as it was last year or the year before. But I think that this will be something we have in our war chest that we can use as we figure out what the next combos are in targeted and immunotherapy approaches.
And that's one of the keys, right? Like having things in your back pocket while you're waiting for sort of the next best thing. And I know a lot of times people people do balk at chemotherapy because it's not a targeted therapy or it's not an immunotherapy. But chemotherapy is still a good drug. The biggest problem with it, if I'm correct, Dr. Herbst, is that it just attacks all the healthy cells too, right? So this is sort of effectively a way to try to target the chemotherapy to just attack the cancer cells and not your skin cells and your hair cells and all this.
Yeah, but it doesn't quite, this thing has to stay on the linker. It has to get to the cell.
Yeah.
The hope is that there'll be what we call a bystander effect, meaning one cell gets it and then it transfers the killing to the next cells next to it. And I think there's a science to this. Each of the different targets might be different. The linkers, whether it gets internalized into the cell, it's sort of like Trojan horse. Get it into the cell, get it to kill. In breast cancer, there's no doubt these agents are phenomenal. The lung cancer cell is a little bit different, but I think it's a single. Talking the All-Star game tonight, maybe a single trying to steal second, but we still have some work to do. And I'm not totally convinced that these are going to move up to the earlier stages yet. They'll be used in the more advanced setting, give us some more weapons. We got a lot of weapons, but we have to think it might not be our next frontline thing.
Yep. So I'm going to ask this final question, and it's subjective, I guess, but what do you most hope that people take away from this conversation tonight?
Well, you said it, hope. It's never easy to have a diagnosis of cancer. And when you hear about lung cancer, it's tough. But I also want people to know that there has been extraordinary progress, and that to maximize that progress, your best therapy should be the first one. You need to make your best decision. And if it's an early disease setting, you want to make sure you're seen where you have a multimodality group. There are many people who do this well, but you need to make sure that your surgeon and your radiation oncologist and your medical oncologist and your social worker and your supportive care team are all working together, and sit down and go through all the data and make the best decision you can, realizing that things change and you might have to course correct. That's why you might even get another opinion. And then if it's more advanced, still a lot of hope. While we can't tell you that we can make it all go away, you can live with your lung cancer, many people for many, many years. And the immunotherapy, I've seen it for myself. It's over, I have one patient 14 years now, on immunotherapy, doing great. Targeted therapy, I can see amazing results. But we also need to understand that this is an area where you should explore clinical trials. You should think about what's next, what could be new, because the cancer does find ways to become resistant. But I want to assure people that I'm just one of an amazing community. One of the things you ask why I went into lung cancer at the very beginning, I'll end by saying I work with amazing people, and including people like yourself, Danielle, and it's everyone, the patients, the advocates, the foundations, all the scientists, all the clinicians. We as a team, as a public-private partnership with the pharma companies, the pharmas are very important to this. All of us working together, we're trying to figure this out. So I want you to know that science, find the best trial or the best therapy. Nothing's perfect, but know that if the first thing doesn't work, we'll work as hard as we can to find something else for you. And I'm happy to help.
I love it. I echo everything, absolutely everything you just said, Roy, and I can't thank you enough for your words. And you couldn't be more right that community is key. There's a lot of spokes on this wheel, and one that might have been lumping down the road a couple of decades ago is really picking up speed, and it's because of everybody coming together, working together, and getting things done. One last thing I do want to say to all of those of you who have participated in clinical trials in the past, it is because of you that these advancements are being made. So a huge thank you to anyone who is currently or has participated. I don't think we thank those folks enough, but honestly, without you, none of this would be happening. So thank you. Thank you to Dr. Herbst for coming out and talking, first and foremost. To all of you watching live, those of you that will come back, watch post live, Onyx and Ash for the work that they do in editing this meeting down and hosting it up on our YouTube website. Penn Media, of course. Stop by and say hi to the crew in the back room. If you get a chance, they come out every month and make sure that we can bring this to you in your living rooms. Michelle Zay, obviously, for moderating every month and being sort of the silent human behind making sure that all of this happens. A huge thank you to her. Our supporters, Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Mirati Therapeutics, Novartis, Novacure, Regeneron, Sanofi, and Takeda Oncology. Without your support, this also wouldn't be possible. And until next time, Roy, I will see you next week in Southern California. Have a wonderful time in Florida and safe travels out to the West Coast. And we'll see everybody next time.
Thank you all very much.
So I'll be brave if you're brave. I'll be brave, but only